I was just trying to fit into that role in that first week. And she said, well, actually, my expectation was, this is your first week as a registrar.
Yeah.
You aren't supposed to know that much. You aren't supposed to make the, I wouldn't expect you to be that autonomous from the get-go. And I would expect that there's a learning curve.
Hi there, Anthony Llewellyn here, the Career Doctor, back again. In this series, we're talking to specialty trainee doctors about how they manage the sometimes tricky transition to what we call a registrar role here in Australia. By the way, if you're enjoying these videos, then I'd ask you to like, comment, subscribe and turn on notifications. I love to stay in touch and hear from you. In this next video, I talked to Elie, who is an advanced trainee in neurology and doing research into neurodegenerative disease. He's actually a fellow with the Brain and Mind Institute in Sydney at the Royal Prince Alfred Hospital. So when you step up to the specialty trainee role, you get to deal more directly with what we call the bosses here in Australia, or the admitting medical officers or the consultants, the specialists that are looking after the patients at the end of the day. Now this can be great if you've got a good boss, but it can be a little bit tricky if you run into a not so good boss or a difficult boss. Let's hear a little bit about that sort of issue from Elie, as well as some other things to think about when you're moving on to the specialty trainee role. Today, we're lucky to be joined by Dr. Elie Mater, who is an advanced trainee in neurology and also is undertaking a fellow position in neurodegeneration at the Brain and Mind Centre in Sydney at Sydney University, or University of Sydney, and also RPA, and is also undertaking a PhD. So busy load there, Elie.
Yeah, quite busy. Thanks for having me, Anthony.
No, that's okay, Elie. I'm glad to have you. Eli's helped us out in the past with the Careers Workshop, where he was a very popular speaker, and Elie and I go back a fair way through various things. The first time we actually met was at a leadership course for medical trainees, and I remember Elie impressed me with his ability to connect other members of his team in a conversation in a task that we threw at him at the first workshop on the Central Coast. And I think we'll probably maybe come back to the the issues of working in a team and how you can sort of what you can do around that and its importance as a registrar at some point. Elie, we like to start off this series with a bit of a life-work balance question. So would you mind telling us a little bit about yourself as a person and what do you like to do when you're not being a doctor?
Yeah, sure. So I'd be very keen to discuss the work-life balance kind of question, because I'm still skeptical whether it exists or not. But so basically, when I'm not a doctor, which these days is a little bit more frequent, I'm actually doing more research, but I still feel like it's within the same realm. The kind of things that I do outside of medicine and research are generally spending time with my family. I like painting, I like playing piano, I like engaging in sport and exercising, but just the standard things, I guess. There's actually quite a few things that I try to be involved in that are sort of classified as extracurricular in a way, because I actually enjoy them, but I think it also helps me develop more as a person. And I think those sorts of things are being involved in sort of foundations, committees. So I'm part of the Australian Lebanese Foundation, which is a cultural organisation. I'm part of the Australian Lebanese Medical Association, and I sit on executive committees for those. I'm involved in On the Wards, which is sort of a website targeted for pre-vocational trainees. And so I guess I find a way to fill up my time quite quickly. But outside of that, I'd like to think I'm just doing normal human being type things, I guess, just spending time with family and exercising and those sorts of things. Cool.
And I found out just today that there's going to be a new addition to your family this year. Is that right?
That's right. So we're expecting the birth of my first child in April, so in a few months' time. So that will also consume quite a significant amount of my non-medicine life, I suspect.
So congratulations.
Thank you.
We look forward to a photo of another baby on the ward site. The last time we put a photo of one of the contributors' babies up on the site, it broke the site.
Yeah.
So we'll see if we can do that again.
Right. Okay. We'll have to invest in some cute clothing.
All right. So, tell us about why did you decide to do medicine? What attracted you to medicine in the first place?
I think, quite similar to a lot of people. I think does anyone really know what they want to do until they start doing it? I'm not sure. But I mean, I've always been drawn to medicine because I enjoy science. I enjoy scientific sort of thinking and logical thinking. I enjoy spending time with people. I did an honours degree actually before doing medicine. I did a science advanced degree and I did a physics degree beforehand. And during that time, I actually did some research with with quite a prominent professor. It's a physics professor. He does a lot of brain modeling. And I remember him speaking to me going, "So, you sure you want to do medicine?" And I said, "Yeah, I think so." He's like, "But you like science, don't you?" And I said, "Yes, I do." He's like, "Okay, well, just know that they're different things. And that if you want to do medicine, just remember you've got to like making sick people well. And you've got to like being around sick people." And I think that is something I actually did like, not so much being around sick people, but actually being around people. And I actually think it's an enormous privilege to be around people when they're in their most vulnerable situations. And I think you grow up very quickly and you see a lot of aspects of humanity. And those are kind of more retrospective thoughts. But, the prospective thoughts thinking was, I like people, I like science, I like human physiology. I want it to be tied in with some sort of service to society, and it just seemed to fit those things. And there's definitely other jobs that can fulfill those things, but I think that was most suited to me.
And yeah, look, I think there's a lot of options in medicine as well, aren't there? If you're wanting to have lots to do with people and providing services, plenty of jobs within there, and most aspects of medicine have an element of that. But also, if you're wanting to then blend science back in, then there are opportunities to do that. And I guess your career's kind of come around back to the physics and the brain science a little bit lately, hasn't it?
It has, and I think that's the great thing about medicine. When people ask me, "Oh, should I do medicine? Is it right for me?" I think that yes, in the beginning, everyone's kind of on a similar path in medical school, intern residency, but where you end up in medicine is so diverse. What it's like being a pathologist is vastly different to being a radiologist, to being an ophthalmologist, to being a physician, to being a general practitioner. They're extremely different jobs and lifestyles and actually what you do from day to day. So I think that even when you're within medicine, there's plenty of time to discover more about yourself and maneuver to an aspect of medicine or job within medicine that might be more suited to you. So I think it's quite nice. And I think even for me, being interested in research and going down the research path for this part of my career, there's still other avenues even within neurology that are still open to me, whether it's to go into specifically just hospital work or being an outpatient clinic kind of private neurologist, or whether I want to go into hospital management and do things in that avenue. I mean, there's just a lot of diversity to your career, and I think that's one of the attractive aspects of medicine.
So it seems like you've kind of had a path back to this area of neurology and research, and that's something that kind of started even before you got into medicine. So can you just describe your journey to where you are now? What was it always a focus on coming to this point as a trainee in neurology, or did you sort of look at other things along the way?
Yes. Well, there's a funny thing actually, that if you look, I was actually in the local newspaper in year 12. I think they just highlighted a few people who did quite well in the HSC, and I remember there's actual quote on that clipping, and I can't find it anymore, but it actually says, when I grow up, I want to be a neurologist. And I always laughed at that because later on I changed a lot, and I didn't think that that's where I was actually going to end up, to be honest, especially over the last few years. And And I actually have quite a lot of skepticism, I'll just make this point, about people who, within your medical school, within internship, residency, are so fixated on knowing what they want to do. I'm going to be an orthopedic surgeon, or I'm going to be a vascular surgeon from day one of first year medical school. And I think you should just approach those people with caution. I think there's something missing there if they're like that. And I personally was always of the opinion that I had an interest in one scientific aspect of medicine, but I was always open-minded to lots of different specialties. And certainly I could have easily gravitated towards a surgical field, or even when I was a basic physician training, I really enjoyed hematology, I really enjoyed respiratory medicine. And when I was an intern and resident, I really enjoyed critical care medicine and intensive care. I think that the journey to decide to do neurology was actually a lot more difficult than I thought. But ultimately it came down to thinking, well, what is it that I find most fascinating? What is it that's going to sustain me for the next 40 years of my career? When I go to a conference, what do I actually want to hear about? Do I hear about, the latest tool for, knee reconstruction, doing it this way versus that way, or these are my complication rates, or those sorts of things? Or do I want to hear about what's changing rapidly in the field of, either stroke medicine or neurodegeneration, or we've finally cured this or that, and what's causing, what's the neural substrate for attention in the brain? What does it tell us about ourselves and consciousness? And I think those sorts of conferences and that way of thinking is what ultimately led me to gravitate back to neurology. And I did enjoy clinical medicine in neurology as well. So I think that it was an exciting kind of specialty. It's a specialty where things are going to change quite a lot in the next 15 to 20 years. And I'd like to be in a specialty that is changing quite rapidly and be at the head of that. So those were the sort of thoughts that came into mind when I was making that decision. But I'd like to say that I think that people would probably be happy in lots of different specialties. More of a personality aspect, I think, than it is, this is the specialty for you. It's like finding the one partner. There is no the one, I don't believe. I think that, there are lots of good options, and then you change yourself around that person to try to make the best out of it. And I think that's true for most people.
It's a great story there, and quite a few lessons there. I think one is to try a range of things, even if you've got your heart set on one, because it probably, if you still end up back at that one choice, at least you can say you've looked at a few other things and you've confirmed it. I think the other thing is it's sort of, I've spoken about this in other forums as well. I think it's not healthy to be singularly focused on one job in medicine, or even just medicine as a career for that matter, but try out a few things, get good at a few things, because you've then got things to fall back on if plan A doesn't go well for you.
Absolutely.
Yeah, and I think, reflecting on some of the deaths of our colleagues of late, you sort of worry that this sort of heroic doctor thing is being promoted, and you have to be the best whatever doctor out there, and that's not the case. Some days it's actually better to just be a good enough doctor, I believe, and look after yourself as well as the patient sometimes. So yeah, no, I think that's some good lessons there. So so tell us about your start out as a registrar. What was your first job, Eli?
Well, my first job as a registrar was in 2015 actually, and it was in Alice Springs. So I was seconded to a rural term. So I'm normally based in Sydney, and Alice Springs, it's quite different. I was a little bit nervous. I think that's something that you just can't escape, because it's a complete change of roles. And I think what I was concerned more about was, okay, I was going to have to take on a leadership role. I was going to have to make decisions. And for me personally, I didn't want to seem too timid about those decisions, which is just me personally. I think other people deal with it differently. So I was mostly concerned with appearing like I, could do the job, and I think that looking like that was quite important, which is quite funny because in retrospect, so I actually had quite a hands-on consultant in my first week, and I was trying to suggest therapeutic kind of different kinds of management and those sorts of things, and investigations, and trying to be proactive and looking like, I'm fitting the bill. And later on, my consultant actually, I think a few weeks later, when we were discussing this over drinks, she said, "You know what? When you came here, I thought you were just this arrogant Sydney person trying to step in, like looking like you knew what to do and so forth. And it's only after I got to know you that I realized, you're actually an okay guy." But I think I told her I was just trying to fit into that role in that first week. And she said, "Well, actually, my expectation was this is your first week as a registrar. Yeah. You aren't supposed to know that much. You aren't supposed to make the, I wouldn't expect you to be that autonomous from the get-go. And I would expect that there's a learning curve." And I could see that you were trying to eagerly kind of, step into that role. So it was quite funny to look back and with her afterwards and think about how it started off. We got along quite well, and I actually had a good week as registrar. I thought one of the interesting things was on day one, I actually made my resident cry, which is a really strange thing because I thought I got along really well. I wanted to be a good leader and so forth. And what happened was, on the ward round, particularly when the consultant went off and we sort of went and saw some new patients with my resident, I had a resident and an intern. My resident told me that she'd consented this patient for a colonoscopy. And I said, "Oh, okay, well, that's great." But I sort of thought myself as a supervisor, so I wanted to make sure that she consented right. And I also saw it as a learning opportunity for the intern. So I just said, "Oh, great. Well, can you just tell us how you consent for a colonoscopy? How did you consent? What are the risks? How do you..." We also had a medical student. And she started off quite shaky. She mentioned a couple of things, and then she just suddenly broke down in front of me and then went away. And I just couldn't understand it. So, and that was probably within the first 3 hours of being a registrar. So now I have to hold this ridiculous title of being the registrar who made his resident cry on the first day. And it's dealing with people and being a leader. So I had to just sort of recalibrate and say, well, what happened there? Completely unexpected. So in the end, I invited the whole team out for coffee, and we made sure that I sat down with her, and I just said, "Look, so what happened there? So, what could have done better? What precipitated all this?" And it turns out, her learning style isn't so much being asked on the spot to do things. And she said, "Look, it's not something that I'm comfortable with, being in front of people and suddenly having to regurgitate information." In the end, she did know how to consent. And I explained to her why I wanted to make sure that she knew how to consent, but also use it as a learning opportunity. And then after that, we got on really, really well. And I also adopted, I changed a little bit of my teaching style to suit her. And I think she also felt a little bit more comfortable around me, my motives, so that she also started to open up. But it was just an interesting kind of first day, be suddenly struck by, the consultant who was a bit suspicious of me, and the resident who I bullied. No, not really, I didn't bully, but, she, in my mind, that's what I thought I did, is that what? So it was interesting, just completely recalibrating. And most of it was just about dealing with people and yourself in this new role rather than anything to do with medicine and the patient.
Wow.
Which is not what I expected.
Great story there, Eli. Quite a few things in there, but I think my perception is that this is like a classic example of what we call imposter syndrome. You're stepping up to that new role in medicine. This happens to all of us at lots of times of our careers. You're stepping up to that new role and you kind of emotionally feel like you're a bit of a fraud. How did I get here? Someone's going to work out that I'm not a registrar. So you kind of change your behaviour to what you from what how you normally might be to something different. And for those people who
know Eli, he's the least likely person, I think, to make a resident cry or to try and
Good. I'm glad you said that.
upwardly manage a consultant or anything like that. But you were clearly trying to sort of give everyone the impression that you're on top of it, and you're confident. And
I think that's exactly it. And after that week, and after I spoke to the consultant, I just sort of relaxed a lot more into the role, and I thought I was a better registrar for it.
Yeah. And did that feel a bit more normal for you at that point?
Yeah, it did actually. It did, because at the end of the day, you've got to accept the fact that you're still a trainee. You're still not expected to know everything. But also, this is sort of a natural sequence of progression that you've legitimately made, and that you don't have to be a different person or have to step into a different role. You hopefully should have naturally kind of progressed through as an intern and resident and developed the clinical acumen and the skills to be able to just continue on as you are and just be open-minded and continue learning. I think it's the worst thing when people think that they need to know everything. They start off as a registrar. And I think it's also a little bit dangerous too when you try to take on too much responsibility and feeling like you need to be too autonomous and forgetting that you have that supervisor consultant oversight for a reason.
Yeah.
I was PGY 3, so that's only 3 years out of medicine.
And in a different place to where you're used to as well. So you're probably unfamiliar with all the normal hospital logistics and all the other stuff that you got to...
Absolutely. And patient population was extremely difficult, and navigating the cultural barriers. It was a great learning experience. And surprisingly, I learned in that term, I learned more about... most of the things I learned about had nothing to do with medicine specifically, as in, therapies, how to manage pneumonia, all those things. I kind of already knew all that, but it was actually all the things around that. How to manage your role in a hospital, how to take consults, how to deal with difficult, consultants in the emergency department, how to, deliver information succinctly to your consultant, how to deal with cultural barriers between different patient populations, how to deal with a difficult family, how to navigate your role with the intern and resident, and also try to balance and be a teacher and an educator in that role. All those things are the things that you kind of learn more about in the first, in the first 3 months of being a registrar than anything to do with, how to manage this tachyarrhythmia or whatever.
Yeah. And so, we talk about how there's things you can do to ease this transition to a registrar, but I guess it is a transition and you've got to give yourself that time. So it sounds like it did feel quite different for you the first few weeks, but then you sort of eased back to something a little bit more normal. Can you tell us about did you have to do on-call or take or anything in that job? And were there any sort of memorable experiences around that?
So I'll just make a point about the transitioning into that role. Maybe you'll want to talk about it later, but I think it's just a point to bring up that I think there is a shift in psychology a little bit when you become a registrar. You are stepping into a new role. But I think what I did, and I think that I see other really, I see other interns, residents doing, is I thought of myself as an intern. I said, okay, so I'm looking to be a registrar in a couple of years, or as well as when I was a resident. When I go through the ward rounds, I'm going to internally, if anything, think about what I would do if I was a registrar. Of course, the first 6 months, you're still sort of acclimatizing to be an intern. But in the second 6 months, when you've got the job under wraps, you've got to start, I think, transitioning yourself by starting to think for yourself in those roles. What would I do if I was a registrar? How would I manage this patient? How would I, how would I approach this consult? And I think that you start sort of mentally or psychologically adapting to your future role as a registrar. And I think part of that involves thinking and being a little bit autonomous as well, with the guidance of your actual registrar who's already there. I think you've got to start making that transition in internship or residency already before you hit sort of as a registrar and you haven't even thought for yourself. And I think that's really important. I think it's also important, particularly when you've made the decision in August or whatever to be a registrar in vascular surgery, you're going to be an SRMO, or you're going to be a basic physician trainee, you have actually about 3 or 4 months as a resident that I don't think you should waste. I think those are opportune times to try to step up into the registrar role, where you can speak to your registrar, tell them that you want to take on a little bit more responsibility, that you want to do that admission in the emergency department for him or her, and maybe even get them to supervise you, slowly getting into that role, because I think that's how you naturally move into that registrar position, because you've already been thinking like a registrar for the last 3 to 4 months. Now you actually just have to go and do it. So I think that's really important to say first up, and that's what I did. And maybe I thought, personally, I felt a little bit more comfortable to some of my colleagues, maybe because of that you've already thought of yourself as a registrar when you're in the middle of your residency and you've started to take on that extra responsibility. When you go to the Met call or the emergency call, think about how you would organize it. Or a couple of times actually, when I was resident, I actually asked the consultant or the registrar if I could lead the Met call, if I could lead this, and then you can do it in that supervised, sort of graded fashion. And I was lucky enough to have people that, registrars and consultants who are happy to facilitate that for me.
Yeah, it's a point that our other trainees have made, that there are opportunities, particularly when you're a resident, to sort of test yourself out at that level, whether that's leading the Met call, going to the emergency department and starting off the consult. Another good tip is to sort of, see if your registrar would be happy for you to liaise directly with the boss about some of the patients and practice some of that stuff as well.
That's a great one.
Yeah. And so, so it sounds like you had a bit of practice with that. Yeah,
I did. And you asked me if I had any particular instances like that I could remember vividly of my first week or two or so on call or being on take. And to be honest, it's all sort of blurred for me. So I can't remember specifically if I had any particular moments there. I had certainly some very interesting and challenging patients, which were quite memorable. But I just remembered really being kind of over-organized. So that's how I kind of approached it. If I knew I was going to be on take, I was there quite early. I was going through all the patient lists. I was trying to compensate, because I think the way you approach the unknown is you try to control it a little bit more, trying to shift the sort of locus of control to yourself by trying to be as organized as possible and come in as early as possible. But I think one other thing I took away from that week, for instance, when I was in the emergency department and suddenly the way this particular emergency department was run at the time, and I think it's changed since then, is that once they refer to the medical registrar in the emergency department, that patient is your responsibility. So then it becomes, so you might have 10 patients that you're balancing as, to be seen, but just because you haven't seen them, they're still your responsibility. So, the diabetic ketoacidosis in bed 15 that you haven't seen yet and is suddenly, dropping their blood pressure and the potassium is dropping, you haven't even seen it, is actually your responsibility. So you end up managing kind of a small HDU ward full of patients that you don't know, and you don't get that much support from the emergency staff. And I know that's changed since then, but I think that what I was trying to do was do the perfect admission for all of those patients. And I think one of the things I took away was you can't do that. You're going to have to prioritize patients, and at the detriment of your own kind of, vanity or ego of having these perfect admissions. You've just got to prioritize patients and do the best you can with the time that you have, and not worry so much about the fact that, you haven't done every investigation or considered every differential under the sun for this particular patient. So I think that also comes into time management and prioritizing and so forth. But that's something I took away from my first week.
Great. So we've talked about junior doctors already, but I think it is one of the key parts of the role is managing your team, both those interns and residents working with your medical students, your sort of other discipline members, even your bosses. Eli, you've been fortunate enough to do a leadership course through HETI, which is where we first met. What did you take away from that course in terms of how to lead and manage other people and teams? And do you have any other tips for people stepping into the registrar role in terms of people management?
I think that looking back, one of the things that you take away from that course is that there are many different types of leadership styles, and that there are many different types of personalities in people, and that you sometimes have to be a little bit flexible and adapt yourself around those particular personality styles. And I think as a registrar, it is actually a leadership role. There's a lot of leadership involved. In fact, you are usually the team leader for most of the time on the ground, apart from the times, I guess, when your consultant comes in. But as you know, you're kind of holding the team together because you're often the conduit to the consultant. But you're also dealing directly with the interns or residents. So I think it's important to be able to recognize that there are going to be different personalities, that you are going to have to adopt your leadership styles to those personalities, as I kind of found out in my first day of being a registrar. I think that's one of the biggest things I took away from it. I actually enjoy kind of taking on that leadership role, and I enjoy taking on the teacher role. I enjoy that a lot. But I think the other thing about leadership is that you should be leading a little bit by example. And one of the things about how I was when I was registrar, and I try to be as much as I can, is that I recognize, for instance, that the interns and residents are very intelligent. Worked in other professions, and I think that you have to respect that. And I think that there's a lot of self-esteem that can be lost throughout your medical school and internship and residency, and your job is to kind of make sure you recognize them, even for the medical students, and I do that as well, as quite intelligent, thoughtful human beings and not just sort of monkeys. And I think the other thing that you should do is be very willing to help out your interns and residents. So don't be afraid to help them out with their discharge summary. Don't be afraid to do that cannula for them. And I think that when you do that, you sort of engender that idea that you are a team, that you can help each other in those different roles, rather than starting to go into your ivory tower as a registrar, like ivory tower equivalent of a registrar of, well, I'm going to sit in my room and study because I have the entire day. I haven't had any admissions today. My intern resident's working hard to discharge, 50 patients off the ward. I think that sends a bad message. So I think getting as much involved with them, within reason, is a really important thing. So leadership by example, I think, is really important.
I'd agree. We all know that registrar that seems to master the aloof, and sometimes that works because they get all that time in the library to study because people don't want to bother them. But that's not the sort of person that you end up wanting in your team either, because they don't give back. And also I think that point of getting to know every new doctor joining your team, recognising that they've got a wealth of experience beforehand, and just spending a bit of time understanding their motivational factors and learning styles and communication styles can really help. If you can manage to juggle your workload in that first week or so you can get a bit more time with those new people, I think it generally tends to pay off, because you can sort of go through a few key things. You can make sure that there's any gaps that they can be addressed from the get-go, and usually that pays off during the term, because they're more clear about what you're wanting from them, and what the things that they can get out of the term are, and it tends to make your life a bit easier by doing that.
It does, and I think it establishes a good relationship and line of communication between you and the resident and the intern, and they should feel more comfortable to tell you when things aren't going well, or they're getting too stressed, or if they've made a mistake. I think you need to make it clear that it's okay, and that there isn't a huge barrier or step between yourself and them, so that they can feel comfortable telling you about these things, which are really important to patient care.
So what about the other side of the coin there, Eli? You mentioned that once you got to know your first boss, it was a different thing, and she, I think you said it was a she, had a kind of initial different perception of you. any sort of tips about how to work with bosses? Because as a registrar, you know, even on one rotation, you're often dealing with more than one boss, but you usually swap consultants every 3 to 6 months. You have to sort of get used to a range of different styles from consultants. Any tips on working upwards?
Yeah. Well, as you just said, you know, it's important to realize that different consultants want different things. And I think that it's important at the outset. For instance, when I was doing my neurology term, the way it worked at RPA was that you'd actually have a different consultant on call every 2 weeks, just as the way the on-call worked. And they'd be managing all the patients on the ward and all the emergency consult, all the consults and all the admissions. And I think that meant that I had a different consultant every 2 weeks. So I really acclimatized then. I think the important thing was actually speaking to consultant quite frankly and openly at the beginning, and just saying, well, what do you expect in terms of when I go and see an admission? Do you want to know straight away? What's the ground rules? When do you want to be called? Those sorts of things, and being very explicit about the terms of your agreement, of sort of your relationship, I guess, in terms of how you deal with different types of duties as part of your job and how you relate that to the consultant. It makes you a lot more comfortable when you know explicitly what the consultant is expecting. You know, I see people who sort of don't have that discussion with their consultant, and then they are afraid to call them. But it turns out that that consultant actually wanted to know everything about every single person. And it was exactly the opposite of what they expected. So I think it's important that, you know, treat it as if, you know, you've just taken a new job and, you know, at a you know, law firm or in a business, and you've just taken a new job and it's a new boss, and you've just got to establish what the expectations are. I think that's really important. In terms of managing personalities, I think that I was very fortunate. I had a lot of great bosses, and I don't think I had too many run-ins with unusual personalities with my bosses. But I think it's important that you also have an expectation of what the ideal boss should be like, and I think that or at least the minimum expectations that a consultant should have in a hospital, and that would be conducive to good patient care. And I think that comes a little bit more with experience, and there's confidence involved in that. That I always knew that even if the consultant gave me the impression that they didn't want to be disturbed at particular times or whatever it might be, I always made an agreement with myself that if a patient's care depended on me discussing something with a consultant, or I wasn't comfortable, that I was always going to ring that consultant, because I know what a minimum, you know, I know what the expectation is, at least for the minimum amount of care that a consultant should be providing for the hospital. Ultimately, the duty and the responsibility falls on them, not you. And if I was a consultant, I'd want to know if this patient was deteriorating in HDU, or I'd want to know if, you know, I was going to make this new kind of therapeutic decision. And even if you speak to them and, you know, most of the time it'll actually work out well and your judgment is right and they did want to know, and they won't go off at you or anything like that. But even if they do, in the unusual circumstance that there's a personality disordered consultant that does, then I think that you having thought about it and decided upon it beforehand means that you can cope with that a lot better, because you know you're doing what's best for the patient, and that you are actually doing your job well. And it's not necessarily what the consultant thinks about your job, it's sort of how you think your job should be. And I think that's your standards, as opposed to always using other people's standards about your work. I don't know if that makes sense, but I think that's sort of how I approached it.
Yeah, no, I think it's important to approach these things from a values perspective, and often if you can bring it back to the patient, that kind of levels all discussions and settles most arguments. As Eli's saying, you will come across a range of bosses, and you know, some bosses' styles will really fit your style really well, and others will be quite different, and it's good to sort of learn how to work with those. Also, sometimes depending on where you are as a trainee, a certain boss's style may fit well and not so much down the track. So, for example, your boss in Alice Springs probably was a really good fit for first year, but perhaps if you're a more advanced trainee and they're still remaining very hands-on, that might get a little bit annoying.
Yeah.
But there are things you can do about that. And one of the key things is to have a good open discussion with your consultant. And just, what are the things that concern you as a consultant? What do you need to know about what tests you want to make sure are ordered for the patient? Because I can sort that out for you. We'll get the other team members to do that sort of thing.
Yeah, and often it's just a discussion over a cup of coffee in a nice environment. And even if it was, I was at the other end of my training and I was with the same consultant, I would have been comfortable to say, look, I'm aware that I'm trying to transition a little bit towards being a consultant, and I want to try to be a little bit more autonomous in decisions. Do you mind if I see a few patients and let you know what I think? And if you can give me feedback, let me know if I'm managing them well. Just be a bit open, and they'll usually appreciate that.
Cool. Now, physician training, there's a lot of study involved, particularly for basic physician training exams. Any advice for trainees around that? How to balance your study, your work, your life, family, etc.? What did you do?
I think that you should accept the fact that there is not going to be an even balance between work and life during your studying. I mean, if you're working and you're studying outside the work, it's not going to be that balance. But having said that, it doesn't mean that you can still have some kind of balance, but it might be an average over, a 6-month period. So for instance, you know that you're going to spend weekdays sort of studying after work or going to your study group, but then you should leave some time on the weekend so that you're not studying, or that you always allocate and schedule some time in for exercise, which I think is really, really important for sort of, keeping on top of your mental and physical health, because I think that there's a lot of things I think that you have to keep in mind when you are studying as a basic physician trainee and you're looking forward. One note that I'll make is that, so I got married actually in my first year of basic physician training, and it was around September. And as people would know in basic physician training, the exams are in February, and you sort of really start getting into the study quite hard, sort of towards kind of October, November, December, January. Those are the times when you're really ramping up. But I had a lot of people tell me, what are you doing getting married? Or, are you sure that's the best time to get married? You'll be studying for your exams and so forth. It was honestly the best thing that I did, because you've got to remember that I think people come into basic physician training on the back of a mentality that they are still in medical school, that you are still, it's this delayed gratification. I'm just going to pass this exam and then the next chapter of my life is going to begin, and then and so forth. But actually what you're doing is actually living your life. You're actually working. A lot of these people are sort of mid to late 20s. You've got all these other aspects to your life, and other people in the business world, corporate world, but they're also managing their other aspects of their life. And I think that you need to approach basic physician training in these exams as just a kind of an aspect to your job, not at the exclusion of continuing your life. And, I had, unfortunately, one of my friends, she actually made the decision to postpone her wedding, didn't have it in that year, and planned to have it at the end of all her exams the following September or whatever it was in the following year, even though they were both ready, they were engaged and so forth. And unfortunately, she didn't pass a written exam. And in physician training, if you don't pass one exam, you have to wait an entire year at the moment. I think they're looking to change that, but you have to wait an entire year before you sat the next year's exams. And so that meant that next year, she was supposed to be studying for her exam again, and she had planned to have a wedding then, so she had a wedding then. And she just told me how silly it was that she postponed this important thing in her life for these exams. And I think that people in sort of country areas have a little bit more of a grounded view of where the exams sit in their career progression. It's just a part of your journey as a career, but it's not the kind of a big barrier exam and then your life is going to start afterwards. It's all quite a continuous transition. And I think that you get caught out if you keep postponing things about your life for exams. And I would very much discourage it. I think plan for important things in your life, plan for holidays, plan if you are having a wedding or if you're getting married, continue those aspects, because you should see the exams as just one aspect of a very long career path. And if you keep that perspective, it'll allow you to stay a little bit more grounded. Don't miss your best friend's wedding, which one person did, just because it was a week and a half before their written exam. You should plan around. And I think there's something to be said as well about being organized and scheduling in those times for yourself to exercise, to go out, to spend time with family. There's always a guilt factor during your study work period, and I think that's somewhat unavoidable. But you should always, if you have good perspective and you have your priorities straight, you'll be able to schedule in time for those important events and make sure that you do spend time with your family, even if it's a little less than what you used to. They'll understand, but if you schedule it in, I think that you're looking forward to the fact that you're going to see them this week or that week, or you're going to go on your honeymoon, or you're going to go on that trip to wherever, in 2 weeks. Then I think that's really important to do that and plan ahead. That's how I would approach the year of study, is just having perspective. I think that's really important.
I think that's again good advice there, and yeah, look, I think it's tricky. I remember it's a while since I did my basic exams for psychiatry, but there was a period where other things in your life went on hold, but there was a discussion before that, and also a bit of a deal that after it all happened, that we'd give a little bit more back to that other aspect, because all this free time suddenly appeared again, which was good.
Yeah.
As well. Yeah.
There's that too, yeah. Setting expectations with your family and friends about the fact that this is only temporary.
So look, lots of good stuff covered there, Eli. You might have other tips for some of the junior doctors that are watching this webinar, but I guess my final question to you is, some junior doctors may be watching this webinar at a time where they're about to do that transition from a resident to a registrar and trying to get prepared. Sort of, if it can be a bit of a weird time when you've got that registrar job but you're still working as a resident. Do you have any advice on how to manage that time in your career?
Well, I think I touched on that a little bit earlier, which is, instead of seeing this huge step up from your role as a resident to being a registrar, it's actually approaching a registrar and taking on a little bit more responsibility. Doing the ward rounds on your own, where you can, or leading the ward round, leading a MET call, doing the admission in the emergency department, just gradually sort of transitioning into that role in a supervised way, which you won't necessarily get when you are a registrar. So I think that's really important, not to waste that time. I think it's important also to enjoy it. I think, as when you're coming towards your end of your residency or SRMO, you're actually really good at your job, and it's really easy. And you can kind of enjoy the patient interactions if that's what you enjoy. You can enjoy going through the medicine and thinking about the medicine without having to do all the other stuff. And sometimes it's enjoyable to sit down and just do a mindless kind of discharge summary and you're not studying or so forth. So I think enjoy it, but just kind of gradually start exposing yourself to that role throughout that time. And I think that's the easiest and best way to do it. And draw on your resources, draw on your registrar and ask them for their advice about what they should be doing as a registrar, because everyone will have their own experiences and their own advice. And it'll not necessarily be the last time, but it'll be close to the last time when you're in that really supervised role and there aren't that many huge expectations on you, and you can ask whatever questions that you want. And you can make a few mistakes, in a supervised way. So definitely take advantage of it, enjoy it, and try to step up into that registrar role early. And, if there are other things that you want to be doing, extracurricular courses, or whatever it might be. I found resident year was a good time to do the leadership course, because it sort of sets you up for getting into that leadership position and role when you're a registrar. And when you're a registrar, you're, as you said, balancing often study and work, and you won't necessarily have time for all those extracurricular programs. So, try to take advantage of it where you can.
Yeah, I think that's a good point. It's a good time to sort of try and introduce some more balance into your life before you get busy, so that you've got to like at least take things away rather than sort of just become too focused on medicine as a career. So, you know, I've said this to medical students: if there were things that you used to do but you put on hold through medical school, maybe bring them back. You know, if it's like doing badminton or you wanted to learn a language, it's probably a good time to start doing that stuff to give yourself a bit of balance. Yeah.
Absolutely. I might mention something, but at the risk of kind of making people a bit anxious, and I don't want to do that, and it's not at all important, but I think that when you are in that second part of your resident year, as you said, you will have more time. And if there are specific career goals as well that you want to meet, as well as life goals, I think whether that be you want to take on a quality improvement project in the hospital, you know, you want to do that research paper or whatever it might be, that's a good time to do it, because you're going to spend a lot of time. You won't have that time as a registrar because you'll be adjusting to the new responsibilities. You're going to be studying, and you're going to be maybe a little bit more busier in terms of your workload. So that's also time to plan in addition to all the important life things, you know, learning language, playing a guitar, whatever it might be, is actually making time in your week to maybe hit those goals. So because I don't think you're going to progress too much on them as a registrar. So if you have a research project or quality improvement project or wherever it might be, that's the best time that you'll be able to contribute as well, given your time constraints.
Yeah, look, again, good point. And some colleges have a few things that, like a scholarly project now, where they might accept something you've done beforehand. So there might just be that sort of small opportunity to get that paper done and then that thing's out of the way. But I tend to advocate for doing
I know. I think that's important. But if you did have that on your list, that you really want to do and you valued that, then I think that that's also a good time to go into. But by no means is it good advice for everyone.
Cool. Anything else you'd like to say, Eli, to our audience?
Not really. I think we've covered a lot of things. I think, and just remember that, you know, you will have your own style as a registrar when you make that transition, and there's no perfect mold, and continue to learn from the people around you. So try to emulate the best things about the consultants and registrars that you work with, the good ones, and try to avoid bad things around you and make a mental note of them. Also, I always try to remember this, because when you start as a registrar, you're going to be asked all these questions about, tell me a time when you had a difficult patient, tell me a time when you called, just like you asked me at the beginning, what was your first week as a registrar? And I have a lot of trouble remembering them. So keep track of those important events when they happen to you as registrar that you can reflect on, because they'll come in handy when you come and do your interviews into advanced training or whatever it might be, when you're going into advanced training. So that's important to keep in mind. And one more thing, which is use your time as a resident and registrar to think carefully about, especially in physician training where you have to pick a specialty, and some surgical specialties it's not that important. You're already an orthopedic surgeon, you're already a neurosurgical trainee. But in physician training, you don't get much time at the end of all your exams before you have to apply to what you want to do. So try to use that time wisely to make the decisions about your specialty and really get into it and ask questions from consultants. Because I think that often gets forgotten when you're in that mad rush and you're studying and you're going from one exam to the next, and then suddenly you've passed, and then they're saying, well, what do you want to do for the next 40 years of your life? And you haven't really thought about it. So try to think about that prospectively rather than retrospectively as you're going through your training.
Well, thank you very much, Eli. It's been great talking to you again today.
That's okay, my pleasure.
Really appreciate the advice. We might put a link to that HETI leadership course in the notes for this webinar as well, so people can find that, because it is a really good course. And
it's an excellent course.
I'm biased because I was responsible for it for 4 years at HETI, and I was at HETI, and I've been advocating it for other trainees to do. But thanks again for your time.
Thanks for having me on.
Cheers.
So I hope you enjoyed this video series on stepping up to being a specialty trainee. If you like the videos, then leave me a like and leave me a comment. If you love the videos, then subscribe and turn on notifications. It helps me out, and it helps you to know when there is a new video ready for you. Until next time, see ya.